Good afternoon, everybody, dear chair and dear colleagues. I would like to present my PhD thesis. My name is Eszter Virág-Tulassay, and I am working as a resident doctor at the Department of Orthopedics at Semmelweis University, and I am a second-year PhD student. My vision is that in the future, shoulder dislocation will not be a long-term limiting injury for young people. So my mission is finding the best choice therapy for each patient with anterior shoulder dislocation. Because of that, I have two specific goals, and I would like to present my first one, that is Bankart surgery is the most effective therapy for first-time anterior shoulder dislocation. It's a systematic review and a network meta-analysis. Shoulder dislocations are about the 50% of all joint dislocations, and 90–70% of this being an anterior one. But the problem is that acute shoulder dislocations are associated with significant pain and a lot of tissue injuries, and we don't know which is the most appropriate treatment option. Maybe conservative treatment is enough or surgery is needed, like soft tissue surgery that we call Bankart. So our aim is there are currently no international recommendation for appropriate intervention, so we would like to provide evidence on this problem. Our clinical question is really simple. Which therapy is the best for patients with acute anterior shoulder dislocation? We use the PICO framework. Our population was patients with acute anterior shoulder dislocation, and we compared the immobilization in internal rotation, immobilization in external rotation, and the Bankart surgery. We have two main outcomes. The first one, the safety, like redislocation rate, subluxation rate, and instability. And the second one is the efficacy, like return to sport and scores. Our hypothesis was that Bankart surgery has the highest efficacy and the lowest rates for complication for acute anterior shoulder dislocation. If we have true, we can help for the surgeons to find the best choice therapy for each patient. You can see my systematic search and my flowchart selection. My search kit contains 4 domains, and we made the search November of 2023. We started around 2,000 articles, and after the duplicate removal and the title abstract selection, we ended 19 eligible full text. And now I would like to present my results. The first one is the redislocation rate after the intervention. We have 2 endpoints, with maximum and with more than 24 months follow-up time. On the network plot, you can see nodes. Every node means an intervention, and the size of the nodes means how many studies we have about the intervention. The connection between the nodes means how many studies compare these interventions. On the league table, on the right corner, you can see the direct comparisons, but we have indirect comparisons too, and the network pool contains both of them. You can see that on the left corner. And it shows that arthroscopic Bankart repair has 18 times less chance for the redislocation than immobilization in external rotation, and 8 times less chance than immobilization in internal rotation. Immobilization in external rotation has 45 times less chance than immobilization in internal rotation. P-score shows that which therapy can be the best. It's from 0 to 1, and arthroscopic Bankart repair has the highest P-score, is almost 1, so this can be the best therapy. With more than 24 months follow-up time, we can see that the network plot is not complete, but it's not a problem because we have indirect comparisons. And on the league table, we can see that arthroscopic Bankart repair has 14 times less chance for the redislocation than immobilization in external rotation, and 12 times less chance than immobilization in internal rotation. Immobilization in external rotation has 90 times less chance than immobilization in internal rotation, and the P-score shows the same, that arthroscopic Bankart repair has the highest P-score, is almost 1, the statistically significant and clinically relevant. Our second outcome was the subluxation rate after the intervention. We have only 1 endpoint with maximum 24 months follow-up time because we didn't have enough data for the second one. The network plot is complete, and on the league table we can see that arthroscopic Bankart repair has the lowest chance for the subluxation, and immobilization in external rotation has lower chance than immobilization in internal rotation. The P-score shows the same, that arthroscopic Bankart repair has the highest P-score, that's almost 1, so it's statistically significant again. The third outcome was the instability after the intervention with maximum 24 months follow-up time. The league table shows us that arthroscopic Bankart repair has the highest stability, and immobilization in external rotation has higher stability than immobilization in internal rotation. The p-score is the same as the previous ones. Arthroscopic Bankart repair can be the best therapy. The fourth outcome, a return to sport after the intervention. With maximum 24 months follow-up time, we can see that arthroscopic Bankart repair has the highest chance to return to sport, and immobilization in external rotation is better than immobilization in internal rotation. The p-score is the same. Arthroscopic Bankart repair has the highest p-score, is almost 1, as statistically significant and clinically relevant again. And with more than 24 months follow-up time, the results are the same. Arthroscopic Bankart repair is the best, then immobilization in external rotation is the next, and immobilization in internal rotation has the worst results. And our last outcome is the subjective scores after the intervention with maximum 24 months follow-up time. The network plot is complete, but the p-score is a little bit different because immobilization in external rotation has higher p-score than arthroscopic Bankart repair, but is statistically not significant. Of course, we have strengths and limitations. The strengths that we used only randomized control trials. Our participants was age-matched, and it's a complex and a comprehensive analysis. And the limitations are a low number of participants, few publications to include, and missing data for important variables in some studies. But our conclusion is really clear because our results was all significant. Bankart surgery has the lowest dislocation rate and therefore the highest safety after 24 months of follow-up time. So the implication for practice that immobilization in internal rotation is not recommended after the acute anterior shoulder dislocation, and we should focus on the surgery techniques like arthroscopic Bankart repair. The implication for research that further prospective data collection is needed to evaluate the efficacy and safety of available therapies. We submitted our article firstly to the British Journal of Sports Medicine, but it was not successful, so now we submit to the American Journal of Sports Medicine, and we are waiting for the answer. I would like to present my second topic. It's accuracy and consistency of 3D MRI is comparable with CD-CT in assessing glenohumeral instability. It's a systematic review and a meta-analysis. Following recurrent shoulder dislocation, up to 90% of patients may experience glenoid bone loss or Hill-Sachs lesion. And we have a several imaging test before the surgery, like MRI for the detection of soft tissue injuries and CT for detection of bone tissue injuries. But what if 3D MRI can do both? So our aim is the comparison of the accuracy of 3D MRI and 3D CT in the assessment of bone injuries after the recurrent shoulder dislocation. Our clinical question is that what diagnostic imaging tests are needed for surgical planning. We use the PICO framework. Our population was patients with recurrent anterior shoulder dislocation with bony lesions, and we compared the 3D MRI and the 3D CT. Our outcome is the detection of presence and size of bony lesion. Our hypothesis is that 3D MRI is suitable to measure the bony defects as well as soft tissue injuries. If we have true, the clinical implication is that we can shorten the surgical planning. My search contains 3 domains. We made a search in January of 2025. And you can see my project progress that we finished the duplicate removal and we are working on the title abstract selection. So to summarize, I submit my first article, and we hope that we can submit our second project the summer of this year. And I would like to thank you for your attention with my favorite quote from Peter Hegyi, that hope is not enough. Thank you.
I would like to ask you that the different etiological factors did influence the outcome of the etiology. For example, it was the same if the patient have had a primary trauma or congenital multidirectional instability, for example.
Yeah, we only selected those articles that are about the traumatology reasons, and we planned our study that the age will be matched, the etiology will be matched, so we can compare everything, and it will be significant and reasonable.
Thank you very much. And what do you think? Is that a matter if the patient has this or that?
Yeah, of course.
I have a technical question. If it is a must to present the results that way for the meta-network plots, because it's very, very difficult to understand, isn't there a better visualization or something to show the results? Because I tried it several times, you remember, but it's still not easy to understand for those triangles and
Sorry, but it's the way by the network meta-analysis.
Okay, but it's you can find out how to show it on in the paper or in a better way, or I don't know.
I tried a lot of way, but
okay.
maybe it was the best.
Yeah, okay.
Maybe you should ask the experts in the methodology and the statistical analysis.
Yeah.
I work on it a lot.
Okay, I appreciate it. Yeah. Okay, thank you very much, Eszter.
Yeah, excellent presentation, congrats. So we saw very good results from your first project, even significant, and the surgery was far better compared to other interventions. So why do you think it's necessary to, impact for research was more studies are needed? So why do you think we need that?
Sorry?
So the results were quite clear, and surgery was far better than the other interventions. So why do we need more studies as impact for research?
Because we have a lot of etiology, for example, and we have only 19 RCT. I think that it can be more. But yeah, you have true. It's my how can I say? It's my lucky that our result will be so significant. But we have a lot of etiology, we have a lot of age groups, so we can check a lot of other things.
Thank you, and good luck for publication.
Thank you.